And moving into the first case of a 30-year-old male who was found down. Chief complaint was that he was unresponsive. PPE usage by the crews were documented as full protection appropriate for any condition. Primary survey is that this patient is unresponsive. His airway was open, but he wasn't protecting, and that he was pink, dry, and cold, pulseless with no active bleeding. Vital signs were obtained within immediate patient assessment, noting that he did not have a pulse palpable. Blood pressure was not taken. His respiratory rate was 4, based, I believe, it wasn't indicated on if that was spontaneous or assisted, as fire was on scene already. His GCS was 3, and he was presumed to be about 90 kilos. Past medical history obtained from the bystander, which reportedly was his friend, was that he had a history of substance abuse, including IV drug use, and that he had smoked some fentanyl prior to going unresponsive, and that the bystander had started CPR. And just as a reminder for anybody else who's listening in, to make sure that you have your mic muted. Obviously, I can't mute the calls in for this lecture. So, as mentioned earlier, patient assessed immediately upon arrival, no pulse. CPR was resumed with BVM. With CPR, shortly after continuing CPR, the patient awoke and started to vomit. At 2 minutes, his repeat vital signs at that point had a heart rate of 64, blood pressure 160/90, respiratory rate of 4, and a GCS of 3. He was given 2 milligrams of intranasal Narcan. And mind you, I want to point out that although this is what I'm reporting to you guys, that was documented in the pre-hospital electronic medical record, the emergency room electronic medical record stated that he may have received Narcan by his friend, which would make more sense for why he woke up with CPR and then later got Narcan again from us. So an IV was established at 4 minutes. At 6 minutes, he received another 0.5 milligrams of IV Narcan. He sat up, he ripped out his IV, he was responsive but confused. Second IV was established. Repeat vital signs at 9 minutes shows that he's now tachycardic, hypertensive, and tachypnic. 11 minutes, his end-tidal CO2 is documented at 57. A 12 lead was obtained, which this was the only tracing affiliated with the chart. Hard to interpret, lots of artifact, looks at least narrow, complex, and slow, not tachycardic. The patient had reported he couldn't breathe. Breath sounds were assessed at that time. He had coarse breath sounds bilaterally. His pulse ox was 88%. He was placed on nasal cannula oxygen at 21 minutes, and at approximately 25 minutes, he was transported. He received 8 milligrams of Zofran en route. His repeat SpO2 was now 94%, but he was on a non-rebreather at that point. And another set of vital signs showed improvement in his heart rate, as well as his blood pressure. His respiratory rate decreased to 19. His GCS at that time was normal at 15, and his end-tidal CO2 was 32. And he arrived at the hospital 43 minutes after initial patient contact. As for pre-hospital care, thought that assessment, care, and documentation was all appropriate, good, excellent. Things that we can improve on is getting a blood glucose, especially if it took a while for the patient to become back to a normal GCS, especially as we know that this patient has ingested something, drugs, maybe other stuff too. The details I put in here because the patient, the way that it's written is that he didn't receive Narcan until EMS arrived, which wouldn't explain why he awoke from CPR. I would explain if he did get Narcan by his friend beforehand, and that if the patient was cooperative and he had crackles in his bases, trial of Cpap might be helpful to try to help with his hypoxia and his presumed bronchi or edema, but probably edema in this case, to be concerned about in the pre-hospital setting. So in the emergency room, they document that he had 10 minutes of CPR. I'm not sure. They said 10 minutes of CPR by EMS. We had reported or documented that we did maybe 2 minutes of CPR. And that they also document that the patient had significant, for a 30-year-old, significant bilateral lower extremity edema pitting 2+, and that the patient had reported this was his baseline without any previous cardiovascular disease or heart failure. His urine drug screen was positive for meth, opioids, and marijuana. He received another 0.5 milligrams of Narcan at this point based off of how much Narcan he received in the field. In addition to requiring Narcan for an inadequate respiratory rate, he was started on a low-dose Narcan drip, and then he was placed on BiPAP as he was still short of breath and requiring maximum amount of non-rebreather support. His troponin, his basic natriuretic peptide, which is a marker for heart failure, was normal. His COVID was also negative. He had a CT of his chest that showed multifocal opacities, extensive, that they thought was likely related to aspiration. And then during his hospitalization, he did have an echocardiogram that showed that his ejection fraction was normal, although they noted that his left ventricular function was low, and that pulmonology was consulted given his hypoxia requiring supplemental oxygen, and they felt that likely this was related to aspiration, so they had him complete a course of antibiotics, although they did try some diuretics, and he was discharged with steroids. He was discharged on hospital day 4. Anyone have any questions regarding this case? Want to speak about it before I move into the teaching points? All right. So I wanted to talk a little bit about one of the differentials when we deal with patients that are hypoxic after an opioid overdose. This patient likely aspirated, maybe if he had CPR done for 10 minutes, he had some pulmonary contusions. Those would all be acute incident related reasons for his continued hypoxia. Another reason with his lower extremity edema is that he had endocarditis from IV drug use due to vegetations on his valves, and that he was in acute heart failure. So those would be 3 top differentials. And the fourth, or on your differential list, could include naloxone-induced non-cardiogenic pulmonary edema. So it's a long word or a long diagnosis for a condition that occurs with opioids and opioid reversal. It's pretty uncommon, and both the opioid itself and the opioid reversal can contribute to non-cardiogenic pulmonary edema. And the pathophysiology is believed to be, in regards to naloxone, due to unrestricted catecholamine surge once the patient has had reversal, and that the pulmonary vasculature becomes quite constricted, leading to pulmonary hypertension, causing them to also develop the pulmonary edema. And then a third contributing factor for naloxone is that as the patient's opioid overdose is reversed, they start to have the urge to breathe, but they're breathing against a closed glottis, which leads to negative pressure pulmonary edema. And as for the opioid itself leading to non-cardiogenic pulmonary edema, is that the opioid leads to histamine release, the patient develops hypoxia, they become acidotic, and all of that leads to leaky pulmonary vasculature. So the takeaway from this is that if you think that your patient has pulmonary edema following an opioid overdose that you've treated, you should use Narcan with caution, as in use Narcan the minimum amount necessary to awake the patient and to allow for adequate respirations. I'm not saying that you should avoid it, but avoid usage. You should just not overshoot it, hit it with a sledgehammer as opposed to a finishing hammer. And the other thing is that this patient, if they do have non-cardiogenic pulmonary edema, Strong consideration might need for positive pressure ventilation. That would be, in our case, Cpap, potentially even needing to be intubated. And then these patients, there's case reports that go on to that they become so hypoxic with such significant pulmonary edema that they're treated very much like ARDS and need to be potentially placed on ECMO. So going over our region's protocols, basically the screenshot on the left with poisonings and overdoses, having you kind of look at the treatment. So universal patient care, identify and manage shock, identify and manage altered mental status, manage airway problems as necessary, contact-based medical control or poison control for guidance. And then moving over to the right-hand side of the screen in regards to the opioids with respiratory depression. If you're a BLS provider or you can't obtain an IV, you can give naloxone 2 milligrams intramuscular or intranasal every 5 minutes up to 8 milligrams. If you have an IV, I know we oftentimes just hit them with 2 milligrams, but you may want to consider 0.5 or 1 milligram before going to your full amount for your first dose. And then this can be repeated every 2 minutes up to 2 milligram titrating to respiratory rate. And if no improvement, this can be continued up to a max of 8 milligrams. If they have a methadone overdose, you will likely need to have more Narcan, as the patient will be very resistant to opioid reversal. All right, I don't see any comments in the comment section. So with that, we'll move on to case 2. Case 2 is of a 56-year-old female. EMS gets called for unresponsive patient. PPE usage is maximum for the condition. The patient was found to be alert only to painful stimuli. Her airway was open, but she was not protecting. She was pink, warm, dry with no evidence of active bleeding. Within 4 minutes of patient contact, vital signs were obtained with a heart rate of 113, blood pressure of 141/83, respiratory rate of 20, GCS of 3, SATs of 97%, glucose of 99, and an estimated weight of 100 kilos. Her past medical history includes hypothyroidism and depression. And the history provided to EMS upon arrival was that her husband had last seen her 7 hours earlier before he went to work. He was unable to get a hold of her all day and finally left to go and check on her. He found her on the ground, thought that she might have been seizing or she had some seizure-like activity, and that EMS noted that there was no evidence of pill bottles or alcohol on scene, and that the husband had stated that she did have a suicide attempt 10 years ago, but she hadn't presented any mood or behavioral changes to suggest that she had overdosed. 3 minutes into the call, an IV was attempted, unfortunately unsuccessful. Vital signs, as I already mentioned to you. At 9 minutes, she was placed on a nasal cannula for pre-oxygenation. At 15 minutes, an adjunct was placed, as well as positive pressure ventilation with a bag valve mask. They noted that there was an empty packaging for monkshood, which is a plant. At 17 minutes, repeat vital signs show that she's still tachycardic, pressure's about the same. GCS is maybe a little bit improved at 5. She's still at 99%, and an IV is established at that time. At 19 minutes, she was RSI'd with ketamine and succinylcholine. She was intubated on the second attempt. The first one was an esophageal tube. At 28 minutes, I apologize, I don't have when she started transport, but it's all right. At 28 minutes, vital signs were repeated. End-tidal CO2 is obtained at this time. That's read as 38. And at 40 minutes, vital signs are repeated again, largely unchanged. At 42 minutes, a 12 lead was obtained, which looks narrow and complex, tachycardic, no evidence of ischemia or an arrhythmia besides sinus tachycardia. And at 43 minutes, she receives 5 milligrams of Versed. another set of vital signs, and she arrives at the hospital at 54 minutes. So reviewing this case, I thought that EMS did a good job of documenting the history, pertinent findings, and pertinent negatives, as well as scene awareness, documenting what they were able to see, gather from the patient encounter and the inside of the patient's home, including this empty seed package. They allowed time for the patient to clear a possible postictal period, almost 20 minutes before they decide to RSI her, especially since she's not hypoxic, but clearly is not able to protect her airway, and there should have been adequate enough time for her to start to arouse more quickly than only a GCS of 5. And as for documentation, as for the areas of improvement, I put in documentation and procedures. They did change their documentation, but this is something that we will be bringing up with our EMS stakeholders, because we are a little bit inconsistent in how we document missed procedures. This particular example was that 2 intubation procedures were documented, and none of them showed that she was successfully intubated, although she was successfully intubated. And then additionally, the post-intubation sedation, you can see that after intubation at approximately 21 minutes, she doesn't get her first post-intubation sedation till about 22 minutes after intubation. And we advocate that pain should be the first medication, although there's a possibility that the Narcan, she didn't receive Narcan. Although there's a possibility that if you give Narcan, that it would block the fentanyl that would be provided. We still recommend that administration of fentanyl before Versed, even if Narcan has been used. So in the emergency room, poison control was contacted regarding this monk seed. They stated that you would potentially see hypersalivation, diarrhea, or fatal arrhythmias, that there's no antidote to this potential ingestion or exposure, and that all of the care would be supportive IV fluids, atropine, antiarrhythmics as necessary. Because she had potentially seizure-like activity reported in the pre-hospital setting, she was started on an anti-epileptic, Keppra propofol. She had a CT scan of her head that was unremarkable for any mass or bleeding, and that her husband provided to the physician, which I'm not sure, this happens all the time, why it doesn't necessarily get relayed to EMS, is that she planned to plant the monk's hood in their garden. So she was admitted to the hospital, extubated, but still remained hypoxic, needing supplemental oxygen. She later complained of some pain in her upper extremity that showed a superficial thrombus. She continued to require oxygen. She had some pleuritic chest pain. She was also coughing, and they did a CT-PE study that showed that she had bilateral PEs. She was started on heparin, which is an IV infusion, switched to oral anticoagulation, and she reported that her father had a history of thrombus, unknown etiology. They did an ultrasound of her legs that were negative for any DVTs. She also had an MRI of her brain that was negative for any evidence of stroke, and she was discharged home on hospital day 12. She returned to the emergency room probably within a week of her discharge, complaining of leg pain, left unilateral leg pain. Ultrasound at that time showed a DVT. It was unclear if she had a DVT from her hospitalization that was not identified by ultrasound, or if this was a new DVT in the setting of anticoagulation, but they elected to say unsure what the time course of that DVT, and just to continue the anticoagulation without any dose adjustments. So although this patient didn't appear to actually have taken monk's hood, it's a good opportunity to talk about monk's hood as a plant, because it is readily accessible. So it comes from the kingdom Planta, the family Raniculaceae, the genus Acanthium. the species Nepellus, and it's also known as conite, monkshood, blue rocket, wolfbane, leopard's bane, devil's helmet because of the shape of the flower, the upper petal. It's a perennial. It grows in the northern hemisphere pretty readily. It's a native plant to mountainous regions, and the poisonous aspects of the plant is all of it, but particularly poisonous are the roots and the seeds of this plant. It was first documented to be used nefariously in 1881 when a male was convicted of using it to kill his brother-in-law. And the toxins associated with this plant is that it has multiple alkaloids, but the one that seems to cause the most problems is the aconitine. It's a neurotoxin, and depending on a little bit of organic chemistry, the ester bonds that are associated with the aconitine is that some of the bonds lead to activation of sodium channels, which inhibits reuptake of norepinephrine and leads to pain suppression, but some of the bonds can lead to inhibition of the sodium channels, which leads to its antiarrhythmic properties or the propensity for ventricular arrhythmias. When an individual has been exposed to monkshood, they usually will have abrupt, severe GI symptoms, either burning from the point of contact with the plant. This is usually described as oral ingestion, so they might have some burning, tingling, or numbing of the mouth, but potentially of the stomach region, although it can also be absorbed with a break in the skin from tactile touch, so be cautious if you use this in your garden. Within an hour, the symptoms worsen with severe vomiting, motor weakness, and cutaneous sensations, in that it can lead to cardiorespiratory failure from life-threatening arrhythmia that can lead to asphyxia or death. So the physiologic antidotes for this is atropine digitalis, but as mentioned in the treatment of this patient, there is no true antidote. In addition, the plant is normally associated with a blue or purple flower, but it also comes in yellow and pink. As for our protocol, we don't have a protocol for monkshood because we can't have a protocol for everything, but I think that the most appropriate protocol associated with this would be potentially seizures, so it's a good opportunity to kind of review that. As always, universal patient care. If they're in status, so seizures that continue multiple while you're there or for a prolonged period of time, they're still seizing by the time you arrived, assuming that they've been already seizing for at least 5 minutes. We have the option to give Versed 2.5 to 5 milligrams IV or IO repeated every 5 minutes up to a max of 20 milligrams. And if there's no IV access, it can be given intramuscularly 10 milligrams with a repeated dose of another 10 milligrams for a max of 20 milligrams. Monitor, as always, when you give opioids or benzos, respiratory status, and check blood glucose to make sure that that's not contributing to what looks like a seizure. If the seizure you believe is related to preeclampsia or eclampsia, the treatment of choice would be magnesium sulfate, 2 to 4 grams IV over 10 to 20 minutes. All right. Case 3 of a 69-year-old female found in bed, sick case, I think is what it came out. Shortness of breath is what it came out as. So PPE usage documented as highest level. The patient was found to be unresponsive. Her airway was open, but she was not protecting it. Her skin was pink, warm, dry with no evidence of active bleeding. Within 3 minutes of patient contact, vital signs, heart rate of 103, blood pressure 130 over 74, MAP is fine at 93. Her respiratory rate was 40, her GCS was 4, she got 2 for eye, 1 for motor, and 1 for verbal, and her initial SATs of 50%. She was reported to be on oxygen, so I'm not sure how many nasal cannula liters she was on for 50%. And then her weight was estimated at 50 kilos. Her past medical history includes COPD, and she is a chronic hypoxic respiratory failure patient requiring supplemental oxygen. And the report that was given to EMS was that she was last seen normal 2 days ago. She, at least in those 2 days, lived with her family. She stayed in bed. They weren't able to provide much history. They just said that she was laying in bed, doesn't look good, looks like she's short of breath, and that she hasn't gotten out of bed. They don't know if she's been vaccinated against COVID. And EMS's first set of SpO2 is 68%. So she was placed on non-rebreather oxygen. Her blood glucose was 127, and at 9 minutes, she was placed on Cpap. At 10 minutes, her SATs only increased to 65%. Transport was initiated at 12 minutes. An IV was established after transport, and a 12 lead was obtained 14 minutes after contact. Looks neurocomplex, mildly tachycardic, normal axis, intervals are normal. Just double check. Yeah, normal, and maybe some LVH. So she was given a milligram of Narcan. The least what I could glean from the documentation was that she was on chronic opioids, and they thought that that might help her mental status. With giving her Narcan, it didn't change her presentation, although someone might argue that at 17 minutes her SATs were at 75%, but it was probably just with the ventilation that she was getting or the higher level of oxygen. She was given another milligram of Narcan. At that point, 21 minutes into this call, they decided that they would need to DSI her. They gave her 125 milligrams of ketamine. They placed her on 25 liters oxygen, now bagging her, and a nasal cannula at 6 liters. And from that point, she had a substantial increase in her oxygen to 98%, allowing for them to paralyze her with 75 milligrams of succinylcholine. They intubated her with a 6.0 ET tube, first pass success with video laryngoscopy and a bougie. At 28 minutes, they record an SpO2 of 99% and end-tidal CO2 of 87%. And they get a second or another set of vital signs. She's heart rate of 81, blood pressure of 99/54, respiratory rate of 20, GCS of 3, and I believe it was probably a documentation error because from that point, another 61 minutes elapsed before she gets 5 milligrams of Versed, and she received Solu-Medrol. It wasn't documented in the transporting crew's record that the patient received bronchodilators, but the fire report was that she also received Atrovent and albuterol, so she was ultimately treated for possible reactive airway disease. So after review of this case, the use of video laryngoscopy, bougie, and first pass success is always excellent. PPE usage, especially with a high-risk procedure, was maximum, and they did a good job of documenting their medical decision-making as well as management completely of reactive airway disease, although the documentation was a little bit lacking in regards to the completeness of it. Now, where we could see improvement is the use of an airway adjunct and head tilt to optimize ventilation. This patient had a reported GCS of 4, so likely potentially obstructing with her tongue. They decided to try Narcan kind of late if they were going to use it at 16 minutes, in that you could argue strongly that Cpap would be contraindicated in a patient that has a GCS of 4, as she is unresponsive, leading for higher probability for tongue obstruction and hypercapnia. We tend to, as a group, place end-tidal CO2 only after we intubate patients. So this patient didn't get intubated until 28 minutes after patient contact, which is an issue, especially if we have a patient on Cpap for, I believe, about 20 minutes. We don't know if we're putting the patient on CPAP for reactive airway disease, she doesn't meet the criteria. She has an absolute contraindication. If we're putting her on CPAP for potential DSI, we have no idea if we are already combating hypercapnia at the beginning. So placing an end-tidal CO2 early will help us determine if we're really not making any headway in regards to her ventilation. Ideally, or we strongly encourage from the MPD's office that you secure an airway before you start transport, optimizing the chances of success, especially when you're not dealing with moving down a bumpy road and you have more hands available. If we're going to use DSI, the options are for CPAP and bag valve mask, as we will review in the subsequent slides. This patient should have been just ventilated with a bag valve mask, and you could see from the time course of her care that once she was ventilated with a bag valve mask, she normalized to above 94% pretty substantially quick. Given that she is an older female, I think she was, let me double check her age, 69 years old, poor PO intake, laying in bed for 2 days, poor history available about her prior history, strong consideration to not use succinylcholine and to use rocuronium for a paralytic for the potential for hyperkalemia in the setting of renal failure or acute on chronic renal failure. Especially if the concern is that rocuronium is longer acting. You've already proven that you can ventilate her with a BVM and CPAP. And I'm not really sure why the choice for a 6.0 ET tube. Ideally, we should be using a 7.5. That one helps to prevent air leaks, two allows for bronchoscopy and prevents somebody having to put a bougie down to exchange for a larger ET tube. So just dealing with the airway overall optimally from the beginning. And then lastly, make sure that you're looking at your documentation. I want to point out that I see a lot of people documenting that times are estimates. Times are always estimates, even in the emergency room, but we're responsible for our times documented. So although they're an estimate, we should be making sure that they're accurate as possible. So a 79-minute transport is probably a documentation error. So case 3 follow-up in the emergency room, she was upgraded to a sepsis alert. She met the criteria for hypoxia, tachycardia, and she was also febrile. Her initial gas showed an end-tidal CO2 of 138. Mind you, we documented that right before hospital arrival that our end-tidal, I believe, was 89%, or I'm sorry, 87 millimeters of mercury. So her end-tidal was 138. Her CT-PE study was negative, and a 12 lead was obtained, which was concerning for a possible STEMI in the inferior leads without necessarily, maybe with some lateral T-wave changes, but nonetheless, cardiology felt that interventional cardiology needed to be consulted to see if she was needing to go to the cath lab, and interventional cardiology felt that this was probably more demand related, meaning that her hypoxia was leading to strain on her heart. She was admitted to the hospital for hypercapnic hypoxic respiratory failure requiring intubation, as well as asthma and COPD exacerbation. She was also found to be meth positive in that her imaging was concerning for a possible aspiration pneumonia. She was extubated in hospital day 2, requiring BiPAP due to rising end-tidal CO2s and encephalopathy multiple times throughout her stay in the hospital. And her hospitalization was further complicated by withdrawal from both meth and alcohol. She was discharged on hospital day 11. So reviewing our protocols for CPAP, we would be placing patients on CPAP if we felt that there was pulmonary edema or reactive airway disease. So pulmonary edema from either cardiogenic or non-cardiogenic causes. Any belief that we are dealing with reactive airway disease, either with COPD, asthma, potentially pneumonia, or CO poisoning. Also for potential submersion injuries. And if the pediatric patient would tolerate it and they met some of these criteria for indication. Absolute contraindications would be that they aren't breathing, that they're not breathing adequately, agonal respirations, or they're unconscious. You suspect or you have a known pneumothorax, or if there's facial injuries or anomalies that prevent you from being able to get a mask seal appropriately. Relative contraindications would be decreased loss of consciousness. They can't tolerate the mask because they're claustrophobic, or they are intolerant of the equipment that we have, or if they have a tracheostomy and they lack the appropriate adapter. Now, going to our delayed sequence intubation, if the SATs are below 94% after pre-oxygenation, and that might be due to the patient being hypoxic, hypercarbic, or they won't tolerate it, we can give ketamine 2 milligrams per kilogram, max of 200 in a single dose over 60 seconds to try to prevent adverse events. And then either if they're breathing adequately, the option would be for bag valve mask with a 2-person seal with a PEEP of 10, or use of Cpap. But if they aren't breathing adequately, it's just BVM. So with this patient documented as such, this would be a patient not breathing adequately, and they should be using positive pressure ventilation with either a BVM or consideration for an SGA. And then once reaching oxygenation above 94%, we're going to be doing a 3-minute countdown to allow for complete denitrogenation prior to paralytic administration. Okay. All right, so moving on to case 4. This is of a 71-year-old female who complained of abdominal pain. PPE usage is maximum. Primary survey is that this patient's awake. Her airway is open. She's protecting. She has a pink, warm, dry skin assessment, and she has no signs of bleeding. Vital signs were obtained prior to transporting agency's arrival, with a heart rate of 70, blood pressure of 170 over 99, respiratory rate of 20, blood glucose of 167, and an estimated weight of 72 kilos. Past medical history includes fibromyalgia and chronic pain, although that wasn't provided to EMS, which is going to be detailed more in the treatment. At least it wasn't provided until near the end. So the story is that the patient was working in the garden and she started to develop severe abdominal pain. She states it was around her umbilicus, it was cramping, it was stabbing, it was cyclic in nature, and when it's present, it's severe as a 10 out of 10. Fire prior to arrival had placed an IV, gave her some, I think 650 cc's of IV fluids, and given her 50 micrograms times 3 of fentanyl for pain control, and the patient basically felt that it wasn't adequate. So another 50 micrograms of fentanyl was given. It's documented that she got a 25 milligram ketamine drip at 5 minutes. And another set of vital signs show that she's mildly bradycardic, hypertensive, but improved from previous reports at 160 over 79, GCS of 15, SATs are 99%. She didn't like how the ketamine made her feel, and although EMS documented more of her quotes, I saved you guys from all of her responses with she didn't like how it made her feel and that she would like it to stop and she needed something else to help with her pain. She received 8 milligrams of Zofran. Not clear if she was nauseated, as it wasn't documented as such, but documented that it improved something, assuming maybe nausea. And at that point, online medical control was called about 14 minutes after patient contact by transporting agency. Online medical control was called because she met the maximum amount of fentanyl available in our protocol, and she was still having severe pain, and the ketamine that she received was not helpful as an adjunct to narcotic management. So online medical control recommended up to 100 micrograms at 50 microgram doses for her, as well as close monitoring with vital signs and SpO2. At 22 minutes, so they started transport at the time that they called online medical control. At 22 minutes, another set of vital signs are repeated. Her SATs have been high, although not documented that she's on oxygen. And she received at 38 minutes another dose of 50 micrograms of fentanyl. At that point, it's documented that the patient admits that she has an opioid pain contract and that she is currently on morphine and oxycodone and had taken it maybe a little before arrival, although stating that she was on low dose, but not very helpful in that information. She had initially provided to EMS that she had no medical history and that her husband said that he didn't know of any medical history or medications that she's on. She became progressively more evasive and non-cooperative, documented as moving intentionally with a blood pressure and not answering any more questions, and that she had made some comments that she felt like she was constipated and taken something for it, but wouldn't elaborate what she took for it. Another set of vital signs are repeated a couple more times during transport that are largely unchanged from the initial. She's still mildly bradycardic, mildly hypertensive stably, and SATs of 100%. A 12 lead was obtained, which shows narrow complex, sinus and origin, normal axis, no ischemia findings, and then she arrives to the hospital 51 minutes after contact. So where we did a good job, I think, in my review of this is that we really were good at adhering to our pain control protocol. 50 milliequivalents, 50 micrograms with a max of 200 micrograms contacting medical control, not realizing that the patient is on a pain contract for chronic pain, as the patient had chosen to withhold that information until after she received 200 micrograms of fentanyl and another 100 micrograms after online medical control was consulted. And EMS did a great job of not just documenting what they felt was going on, but documenting her quotes and her words and her behavior, in that they did serial vital signs with SpO2 with pretty much all of their vital signs. Ketamine is not a drip for this indication. We really don't have any of their ketamine protocol is all bolus or single dose infused over a period of time. I don't know if that's considered a drip. The reason why I mentioned that this is not a drip is because our hospital colleagues have been bringing to our attention their concern about pre-hospital use of ketamine. Not sure if that is related to news and ketamine in the media with more awareness than before, or if we're reporting it to our hospital as something that seems concerning or unusual. So ketamine is going to be a calculated dosage for the weight, 0.3 mg per kg, and to be given as a single amount, not as a continuous infusion. So that will help address any concerns that our hospital colleagues have with us giving ketamine in the field. Mark Muir, I'm not sure, as I don't know our protocol verbatim. If they get opioids, do they have to be on oxygen?
Part of the universal protocol is maintaining appropriate oxygenation, regardless of whether or not they're on opiate or whether they're given pain meds or not. One of the big take-home things here is as they did pretty well in this case, is to give fentanyl first. We're starting to see some cases where ketamine is used as a first-line pain medication. We're trying to avoid that.
Yeah. So I know I don't know our protocol well enough to know that oxygen always has to be administered. Some places feel that it has to be given if you give an opioid, but I all protocols that I've seen has stated that at least a pulse ox monitoring throughout the usage of a benzo or an opioid, which this crew documented well. So I have no concerns, and that's why that's not into the room for improvement section, is that the patient didn't receive oxygen. SATs were at 99, 100% the entire time. We are seeing a lot of antiemetic given prophylactically. That's not in our protocol. So if you're giving Zofran or droperidol for nausea, it needs to be for nausea, not just because you're giving an opioid. And then consideration of an end-tidal CO2 in our patients that we're giving multiple doses of narcotics to, because although our SpO2 might be helpful in knowing that they're oxygenating, we're not necessarily seeing that they're underventilating, and that can be a quicker determination that our meds are causing detriment or side effects that we want to avoid quicker than our SpO2 will pick it up.
Yeah, Jackie, could I just make a comment on that?
Yeah.
So I think we don't have a specific protocol that mandates that you put patient getting opioids on pulse ox. That said, it's almost always a good idea. So the idea is that you monitor the oxygen level using the best clinical information that's available to you. So if you're doing a trench rescue and you can't get them on a pulse ox, then you're monitoring them closely. And then as soon as you practically can, then you're going to have them on a pulse ox.
Yeah, thank you. And if we don't have a protocol for a pulse ox and the patient has a bad outcome, you'll be much more you'll be more successful in documenting your decision making and your care if you have monitored them appropriately. So in the emergency room, this patient had a CT scan of her abdomen pelvis. She had a small bowel obstruction with a closed loop. Surgery was consulted, a nasogastric tube was placed. She went emergently to the operating room. They found bowel ischemia. They resected the dead bowel and washed her out. She had a hemoperitoneum from this disease, and then she completed antibiotics during her admission and was discharged on hospital day 7. So I was, like I said, or I shouldn't say it like I said. I should say that this case was brought up to discuss ketamine, and we are reviewing ketamine usage now, especially as we move into the next month, due to concerns from our hospital colleagues about ketamine usage and concern that it's being used inappropriately. So with that, I thought I'd bring up a couple of studies in the last couple of years that gives us a little bit of information about ketamine that maybe isn't so much as our current ketamine familiarity with agitated patients. So in regards to pain control. So the first one, this was a randomized controlled study, double-blinded and prospective, that was looking at geriatrics over the age of 65 that had moderate to severe acute abdominal pain, flank pain, or musculoskeletal pain, or malignancy pain, and looking at giving ketamine at 0.3 mg per kg. And that reminds me, we actually, our dosage is 0.5 mg per kg. So almost everything that I found was sub-dissociative doses of 0.3 mg per kg. So giving a lower dose than what we actually have in our protocol versus morphine at 0.1 mg per kg over 15 minutes, and that the primary outcomes was reduction in pain at 30 minutes. From that study in the American Journal of Emergency Medicine, it showed that ketamine and morphine did not have a statistically significant difference in reduction in pain between the two, although ketamine in our elderly population was reported to have higher rates of psychoperceptual adverse effects. So maybe something to consider when we're deciding to add ketamine to our our opioid administration is that our older patients may find that it's less calming to them. And then the second study was a meta-analysis looking at studies that are currently in existence. They looked at 52 randomized control studies and 13 observational studies. Basically, from looking at that information, they looked at pain control in the pre-hospital setting, anything from ketamine to opioids to Tylenol IV and to NSAIDs IV, so Toradol, in that they found in their review of this literature that as initial analgesia given IV, opioids are no different than ketamine, Tylenol, or NSAID in reducing acute pain in pre-hospital settings, and that opioids may cause fewer total side effects than ketamine, but more than Tylenol or Toradol, in that the combined administration of an opioid and ketamine may reduce acute pain more than an opioid alone, which kind of leads us into our protocol. So as for pain control in the acute setting, doing our universal patient care protocol, determining what their pain is on a scale of 1 to 10, consider and treat underlying causes for pain, and using non-pharmacological management, so position of comfort, splinting, heat, cold, padding. And then our pain options are going to be the option for Toradol, opioids, ketamine, and nitrous oxide. Paying particular attention to, if you're going to use Toradol, that you don't have any contraindications. So the age range is 2 to 64 years of age. And that the contraindications would be known liver or renal disease, allergies to NSAIDs or aspirin, if they're pregnant, if they're on anticoagulations, if they have a bleeding disorder, if they're a trauma entry patient, or they have altered mentation. So it's not listed here, but my guideline is I don't give Toradol to anybody that I think might be an operative patient, just as a guideline for myself. So I would agree with the decision for this crew not to have given Toradol for this potential potential unknown acute abdominal pain. So fentanyl can be given in 50 microgram increments every 3 to 5 minutes, IV or IM, titrated to relief of pain, and you can be given up to 3 micrograms per kilogram total dose, not to exceed 200 micrograms. To be given over a little bit of time, so that if given as a quick administration, it can lead to chest rigidity and impede airway ventilation. In that the adjuncts to opioids includes ketamine, so our dose is 0.5 mg per kg IV over 2 to 3 minutes, not to exceed 25 milligrams as a single dose. And you have to have already given at least 2 doses of opioids preceding administration of ketamine as an adjunct to opioids. If the pain is severe or there's pain with hemodynamic instability, ketamine is an option at the same dose, IV or IO, over 2 to 3 minutes, not to exceed a 25 milligram single dose. And that can be repeated every 10 minutes as needed for pain control, or until they develop signs and symptoms of sedation, basically. So nystagmus, agitation, ventilator compromise. If IV is not available, such as Dr. Mock had kind of mentioned with the impediment to get to the patient to adequately place an IV, like in a trench, or if they are trapped in a vehicle, 1 mg per kg IM is an option, repeated every 30 minutes PRN for control of pain, or until they develop signs and symptoms that suggest that they are being overly sedated. And then nitrous oxide. I don't know if we carry nitrous oxide in all of our ambulances or fire trucks, but it's there.
So, Jackie, it's just North Country and Camas typically has had it, but I don't think they even have it anymore.
Okay. So nitrous oxide if you have it, but we don't really. All right. So case 5 is a twofer of our favorite call of delivery in the field. First case of a 35-year-old female in a tent camp, I guess you call it. I get called on an OB case for delivery in a tent. PPE usage is appropriate. They find the patient alert. Her airways open, she's protecting, she's pink, she has no evidence of continued active bleeding, although there's signs of previous bleeding. She refuses to have her heart rate, her blood pressure, her respiratory, her heart rate or her blood pressure obtained, but she can't impede them from assessing her respiratory rate, which is 26. Her GCS is 15, and they estimate her weight at 63.5 kilos. Her past medical history is of substance abuse, and I put in homelessness because it does affect access to care. So that's why it's under past medical history for here. And that the story is that she delivered the child in her tent by herself. She delivered her placenta and she cut her umbilical cord. She reports G2, P2. She states that she's had some prenatal care and that her pregnancy was complicated with drug use prior to pregnancy, but she is evasive on answering if she has used drugs during her pregnancy. She reports that she thought her due date was on October 7th, and so she's about 3 weeks early with this delivery. So as mentioned earlier, the vital signs when they first arrived, the patient is sitting in a chair in her tent. She's holding her baby swaddled in a blanket. There's blood on her abdomen and also within the tent. They hear the baby crying and they see the baby moving. The patient's hostile. She doesn't want them there. She doesn't want their help. She tells them repeatedly to leave. This crew did their due diligence to work with the patient, even though that she told them multiple times to leave, and that ultimately they get her to agree to go to the hospital and take her child with them. She says she has no abdominal pain, but she states that she does have some continued vaginal bleeding, but they're unable to assess it because she's not cooperative with any part of her history or her physical besides getting in an ambulance. So in looking at this case, I thought this was a super difficult case, unusual circumstances, which are kind of usual for our parts of our area. They met the patient at a compromise, although it wasn't ideal in that we would rather assess the patient and assess the baby. They got the mom to go ahead and finally agree to come with us to the hospital. And so in order to have that happen, there had to be a compromise in that they used their other senses, their visual and their visual assessment of the patient, of both patients, to make sure that the second infant was looking okay. They did document that the second patient, the pediatric, was pale, but did improve in color en route to the hospital. And they documented a very difficult scene, as well as all of the measures that they did to persuade the patient. Really, I don't have any other suggestions for them. I'm grateful in this particular case that the mom agreed to go to the hospital, but we'll talk about what happens if mom refuses. So this patient was diverted to Peace Health as Legacy was on L&D divert, and she goes straight to L&D. Her urine drug screen is positive for meth and benzos and opioids. She refuses care for herself and the infant. She requires chemical sedation, Ativan and Zyprexa, to even get her to be less agitated. And that she kept on taking the infant out of the warmer, wrapping the infant in a blanket and refusing care to the infant. So finally, the staff took the infant to the NICU to initiate care and start antibiotics. The infant's hematocrit was 27.7, normal range is 42 to 65. And they believe that this child is anemic because mom had cut the cord and never clamped it. Mom did agree to admission for both eventually, and the pregnancy, as documented, is limited as she has sporadic care and large gaps during her pregnancy. Mom is actually G3P2012, which means she's been 3 times pregnant, and 2, including this baby, live births, and 1 abortion, and that this baby was thought to be 31 weeks and 5 days based off of what information that they had during her pregnancy. Postpartum day 1, the mother was agitated and persistently confused. She was found to be walking in hallways. She was found in other patients' rooms after stealing their clothes. Psychiatry evaluated her and felt her presentation was due to her drug use, that she was not holdable. A CPS report was made, and the patient eloped prior to completion of her care, or given resources for what is available for her. She didn't elope very far. I think that the documentation is that she was found in the parking lot of on campus. Security brought her back to the emergency room. She was agitated, requiring physical and chemical restraints. The DCR evaluated her and determined that she wasn't holdable, so she was allowed that one time to go up to the family birth center with security to see her child before being discharged home with a sleeping bag in a tent. Case 2 is a 37-year-old female.
Jackie, what happened to the child?
The child stayed in the hospital. The child stayed in the hospital, didn't need a transfusion. They just as long as the hematocrit wasn't trending down further, so they think it was all acute blood loss anemia, and completed antibiotics, was doing good, as they were stating in that DPS. Anyway, Child Protective Services was aware and was going to be keeping the child. In that, in the note from when mom returned to the emergency room, I guess her first child had a very similar presentation to this child's entrance into the world.
I guess the only advantage is she wouldn't have any likelihood of developing severe icterus after with a low hematocrit like that.
Yeah. And I mean, it's unfortunate because I think that EMS documented that they tried multiple times to do whatever they could to assess the child, the baby. And I think that if they would have had the ability to assess the baby, they would have been able to see that mom didn't clamp the cord. And even at that point, it's a good idea to clamp the cord and try to prevent any continued blood loss. So, yeah. The next case is another OB case. The patient was found awake, airways open, protecting, pink, warm, dry, no evidence of active bleeding was documented from initial primary survey. Vital signs obtained 6 minutes after patient contact, heart rate of 75, blood pressure 158/92, respiratory rate of 20, GCS of 15, and estimated weight of 78 kilos. Mom reports G4P4. She has had no prenatal care, and she thought that she was due sometime in December. She delivered at home. They found mom on the ground with the baby delivered between her legs, and the baby's naked. It's a little bit unclear from the documentation, as the transporting agency's documentation stated that, I'm trying to remember which one's which, but the fire documentation was very complete and very thorough. The transporting wasn't, and there was one documentation that mom had her left arm on the patient's neck and her right arm on the patient's, I believe, chest. And then there's further documentation that the mom refused to touch or hold the baby. So I'm not sure if there was concern that there was clearly concern that this was an atypical presentation response for a mom after delivering a child. But nonetheless, so the mom had reported that she tried to clamp the cord with a shoestring. There's documentation from fire that they could see a grapefruit-sized hematoma next to her vagina. Infant APGAR scores were documented as 7 and documented as 7 throughout the encounter, and that they were able to assess the baby, clamp the cord, and cut it. And then they started to dry the baby in a blanket, handed the baby over to mom to do skin to skin. Mom did not have any interest in having anything to do with touching the baby. It was also documented that mom refused to make eye contact as well when they arrived, which was also strange and unusual. And that mom had taken the baby and started to rinse her off, I believe, in the faucet, despite protests from EMS stating the importance of keeping the baby warm. So online medical control was called 16 minutes after patient contact. Online medical control attempted to talk to the patient as the patient was initially going to come to the hospital, and then elected that she not only wasn't going to come, but she wanted everybody out of her house. It's documented that as she's talking to online medical control, she just puts down the phone without completion of the call and walks away and is further disinterested with anybody being there. It's documented that an attempt at CPS was a CPS report. There was an attempt to make a CPS report, and I believe, Dr. Mock, if you remember this a little bit better, feel free to jump in, but that it was attempted to be reported to the sheriff, and the sheriff said that there was not a CPS, and there was not a incident that met concern for abuse, I believe.
My understanding, the crew was trying to get law enforcement to compel the mother to come in, and the officer was saying, "Well, there's no crime." The point being that it's not a crime, but the issue is child neglect here. The fire crew did file the appropriate CPS report.
Okay, cool. I didn't know the outcome of that. So I thought that really the fire crew's assessment documentation was really superb for this incident. Contacting online medical control for an unusual circumstance is always a good idea. They delivered the placenta, they cut the umbilical cord, they attempted warming. If the patient would allow, especially with the reports of a hematoma, was there potential for uterine atony? Would there be, if the patient was cooperative, maybe a little bit of a fundal massage, and then involving CPS while on scene would be, from my reading of the notes, a consideration that we could work on. Is that agreed upon from you, Dr. Mock? I want to say probably.
Yeah, so, it's depending on the time of day, it can be difficult to get CPS on scene. But I mean, I think the crew did a good job of bringing all the resources to bear to try to get the best outcome possible for this patient.
Yeah. So I did a little bit of searching, which come to find out is also in our protocol, so that's excellent. But anyway, the state of Washington has a law called the Safety of Newborn Children Law, and these are the criteria for this law. So ideally, from birth up to 72 hours earlier, the better, as we know delay in care can lead to worse outcomes. The parent, mom, has the option to deliver the baby to a hospital in Washington. I put that in there because the law says it has to be in Washington, especially in our physical location being so close to Oregon. That might be an issue in if this parent can be protected under the Safety of Newborn Children law. So it has to be a hospital in Washington, a fire department in hours of operation, recognizing in rural settings that they either are not currently manned or that there might be on a call, and then a federally designated rural health clinic in hours of operation. And they have to be dropped off with a qualified person, so an employee, volunteer, medical staff, and they have to be dropped off unharmed. And if they meet all of these 4 criteria, it guarantees anonymity and immunity from prosecution. So, and I brought that up, and I bring up these protocols that we're going to look at in the next 2 slides, because I think that these were particularly hard cases that we hope to, we don't see a lot of deliveries in the field in general, and then you have this added, substance abuse and, potential psychological depression or whatnot, or neglect going on too. So these are rare cases that we hope to not have a ton of experience with in the future, but unfortunately we do have it at least this last month. And I think that, the guidance that I can give for these 2 cases is, I think that the crews did the best anyone could possibly do in these situations, and that that when I thought about what I could give back to these cases for case review is that, if you are dealing with something like this, CPS, if you really can't persuade the patient to go to the patient and the mom to allow the second patient to go to the hospital, if you can't persuade them at any cost to go to the hospital, then should you potentially tell them that, we can take care of your child for you, and you have access to this newborn children, safety of newborn children law. So that's the only reason why I bring up these 2 next protocols, is because if you can't convince the parent to allow her or the child to come, then maybe, and if you can't get CPS there, maybe you can appeal to, we can see, your child can be seen and you won't be in trouble for doing that. And if you're going to do it, you need to do it sooner than later. So normal childbirth, just reviewing our protocols for a uncommon situation. So sterile or clean technique whenever possible. Don't prevent the baby from being delivered if you feel that it's imminent. Check for cord around the neck and gently remove if found. I know in my own experience as a paramedic, I remember seeing a nuchal cord, identifying it by verbalizing it, and then my field trainer saying, and now remove it. So not just identifying it, but removing it. Applying gentle counter pressure to the baby's head as it delivers, trying to prevent explosive deliveries, and assisting the deliverer's shoulders and the rest of the body. After delivery, you want to make sure that you're doing your neonatal resuscitation. Remember, we're trying to ideally get APGARs, I believe it was 1 in 5 minutes. And if no resuscitation is needed, then proceed as below. Wipe the nose and mouth of copious secretions, dry the infant and place on mother's chest for skin to skin. Cover both with a clean, dry blanket. Assess the APGARs at 1 and 5 minutes, and document if there's any lesser score given. At 30 and 60 seconds after delivery, clamp and cut the umbilical cord about 6 inches above the infant. And if resuscitation is needed, just clamp it, resuscitate, and come back and cut. Do not delay transport to deliver the placenta. And after the placenta has been delivered, gently externally massage the uterus to encourage contraction and prevent further bleeding. If the mom has significant bleeding greater than 500 mLs, continue uterine massage and treat for shock, and update the hospital for allowing them the ability to anticipate what might need to be for resuscitation. I will say that as of last night, we got an email at Peace Health where I assume that Legacy Salmon Creek is also in the same situation. We're critically low in our blood banks, meaning that they believe that we have enough for 1 day of regular usage. So they're asking us to be very careful about usage of blood products. So it's going to be really important, and especially always, but especially in times where there's shortages of blood, to make sure that you're allowing for fundal massage to try to help with uterine atony. And then abandoned newborns, which is essentially the law that I had just mentioned, protecting the parental anonymity. gathering the medical history of the parent and child, providing referral information about adoption, counseling, medical and emotional aftercare services, domestic violence and legal rights, and notifying and releasing the newborn to Child Protective Services. And this is anyone under the age of 72 hours old. I will say that when I read about that law for the state of Washington, that the parents don't completely relinquish their right. They still have rights up until the court has made a ruling. So just because they choose to have their child be dropped off in those 3 potential locations doesn't mean that they can't change their mind. But they will be in touch with the child's social worker to discuss what to do at that point. But anyways, essentially this is same, if not similar, if not the same as what I just presented to you guys. So I'm not going to read it further. I did get a hold of a representative from AMR, and they state that it's upon AMR to coordinate with the hospital with a CPS report. So, yeah. Any questions? So in conclusion, kind of summarize what we've talked about here. First one being, if you have an opioid overdose and you are giving Narcan, there's potential for non-cardiogenic pulmonary edema. So be aware of this rare condition. Give Narcan only in amounts necessary to be able to treat the patient appropriately. Recognize that this patient will essentially be like an ARDS patient and will need potentially positive pressure ventilation. Second takeaway is that monk's hood comes in yellow or blue. It's highly poisonous if contacted either by dermal absorption or GI absorption. You're going to have GI complaints and the possibility for ventricular arrhythmias, and all of the care is just supportive. Third case takeaway is that if the SATs are under 94%, your options for DSI is going to be BVM or Cpap. And if you believe that the patient does not have adequate respirations, then it's BVM plus or minus use of SGA to get the SATs above 94%, and then denitrization over 3 minutes. Image on the upper right is of T-Pain, for those who don't recognize him, but also an image of pain, in that we are recommending that ketamine can be used in conjunction with opioids, as it may be helpful in decreasing overall pain when it's used as an adjunct with opioids after 2 doses of opioids have been administered, and that over the age of 65, there might be more complaints of psychoperceptual adverse events. So just be mindful of that. And then the last image is of pregnancy in the field, or not pregnancy, delivery in the field of pregnant patients, and that they're rare, and even rarer are our problems with substance abuse and behavioral issues at the same time. We are in Region 6 in the state of Washington, so the number is 1-866-764-2233, which I called this morning, and it is an accurate number from the website. If you don't have that in your phone or as a reference, you can also call 1-866-END-HARM, which is also a functional phone number I called and made sure this morning. And then lastly, I was asked to talk a little bit about EMTALA due to a recent event. So this is not comprehensive, but hopefully to remind or educate us about what is going on there. So Emergency Medical Treatment and Labor Act is what EMTALA stands for. It was enacted in 1986 as a anti-dumping law, or an effort to prevent dumping from the hospital. It requires anyone coming to an emergency room to be stabilized and treated, regardless of their ability to pay due to insurance or financial means, their origin of national origin, their race, their color, or their creed, and that it states that you cannot transfer without completion of a medical screening exam to determine if an emergency exists. and that it ensures that the patient is stable enough to transfer. If the patient is determined to have a medical emergency and not stable, they need to be treated until that emergency is resolved or it's stabilized. And if the emergency room doesn't have the means to stabilize the patient, an appropriate facility for transfer must be initiated. So it has to be a place that would be able to further help this patient that is not able to be done at the hospital that they are in. It applies when an individual comes to an emergency room. I personally did not find anything that said because you were on property. It stated that when they come to an emergency room, Dr. Whitwer or Dr. Mock, if you know any better, please feel free to chime in. And that it says that hospitals that have the specialized capabilities are obligated to accept transfers from hospitals that lack the capability because of this EMTALA Act, not only referring to lesser hospitals, but also mandating higher capable hospitals to accept the patients to be treated. And the penalties are $100,000 fines for the hospital, $50,000 fines for the physician, and options to sue both the physician and the hospital for the outcomes for the patient.
Right. Jackie, the actually case law is there that has been interpreted that when you come onto hospital property, that is, and you're coming there for a quote emergency evaluation, that is de facto that you're arriving to the emergency department as long as you're on the property, especially if you are on the pad of the emergency department. But it's actually anytime you arrive on hospital property, it's been tested in court.
That's fine. I just pulled this up from ACEP, so
Yep.
that's the reason why I said, I'm like, it says just to an emergency room, didn't say if you are on the corner of the property. So yeah, and I mentioned the specification of to the emergency room or on property, as this recently came up over the weekend that that EMS can't take a patient off of property because of concern for EMTALA violation, but that doesn't apply if the patient has already been evaluated, medically cleared, and discharged.
That's true.
5 minutes of their discharge, calling an ambulance again.
It's always safer for the crew to talk with the emergency department on those cases when they're called to the. I mean, you should automatically be suspect when you're called by a patient to come to the hospital to take them to another hospital.
And I will say that EMS contacted online medical control myself before even getting on scene to get an idea of what was going on. So they were very proactive on that.
Well, that's good.
Yep. So that is all I have for this month's case reviews. Does anyone have any questions?
If I could, just one clarification came up a couple of times today. We amended the protocol in June so that ketamine is the preferred post-intubation sedation agent. Reason for that is just easier to administer. You're going to get more reliable sedation, and you'll also get additional analgesia with it. Versed is also a backup option.
Yes, and correct me if I'm wrong, there is no drips in our protocols for ketamine. It's all calculated as weight-based and given as a dose.
Correct.
Okay.
And it also has a maximum dose, even though the dose is 0.5, it has a maximum dose.
Yeah, 0.5 mg per kg, no greater than 25. And I believe the same for induction, no higher than 200 milligrams as a single dose.
Correct.
Okay. Yeah. Thank
All right.
you for your attention. As always, send us information if you have any questions or need for clarification.